Now, take the solitary myoma, mix up some secondary changes, and make it pedunculated. Now you have a setup for some very atypical sonographic appearances. And that's why fibroids have been called the pelvic mimicker, because they can mimic normal or abnormal pelvic conditions in up to 5% of cases. So let's look at some of these atypical presentations that we should be aware of. They can mimic an ovarian mass. Now here we have a pedunculated myoma with cystic changes, and it looks like an adnexal mass with linear septations and fluid and some solid elements. So it's crucial in this case to find a separate ovary. Here are some more atypical myomas mimicking adnexal masses. Here's an ovarian, quote, mass with the septation. It's just a pedunculated myoma. Here is a pedunculated myoma, another one that had mostly cystic degeneration. Here it looked like perhaps a dermoid because it had some calcification. Here was one that was thought to be a large lymph node lateral to the uterus. All of these are pedunculated myomas. They can even mimic an endometrioma. This was a pedunculated myoma. It had vessels feeding it, but it was so homogeneous that it looked like an endometrioma. Here, this was a huge mass extending up to the xiphoid, and everybody thought it was going to be a large ovarian solid mass. Turned out to be a large pedunculated myoma. Here is a solid mass in the cul-de-sac. Thought it was going to be a fibroma, and it was a pedunculated myoma. They can mimic dermoids. These are the fatty containing lesions with sound attenuation, especially when it's pedunculated off in the adnexa. In this case, it was clearly in the wall and there was endometrium, so the sonohystogram helped us see that it was a myometrial mass, not an adnexal mass. Here's a myoma with tip of the iceberg mimicking a dermoid. Here's another one, sound attenuation mimicking a dermoid. Here's a myoma mimicking adenomyosis. Looks like a bulgy, thick, heterogeneous uterus, and it was filled with these little small myomas. This one had uterine enlargement, was thought to be a sarcoma, and turned out to be just an atypical myoma with some bleeding. They can mimic uterine anomalies. Here seems like a bilobed uterus. Here's an endometrium. Something in here looked like an endometrium. Surgery showed this was just a pedunculated myoma. Another one where it was thought to be a bicornuate uterus. One of these, and I can't even remember which one, was the myoma. Can mimic pregnancy. Large uterus with a big fibroid and a cystic space. Want to do a pregnancy test. Here's that case I showed you, a little embryo here. We thought there was a twin. No, this one stayed the same, was a degenerated myoma, and this pregnancy continued to grow. Here's another one that looked like a little gestational sac. They can mimic ectopic pregnancies. Now here are two different cases, both of which mimicked ectopics. In the adnexa, there was a mass with a hyperechoic rim and something that possibly looked like an embryo inside, except that the vascular pedicle sign showed up here, that we have the vascular pedicle feeding the mass instead of a sort of ring of fire around the mass. And the pregnancy test was negative. This was a myoma, partially pedunculated. Now here was another case, completely separate individual having a very similar appearance. The pregnancy test is negative. This was not a cornual ectopic, which it simulated, but it was just a degenerated myoma. They can mimic fetal heads. This is always fun when you find a fetus inside the uterus and then you see something that looks like a calcified head and you study it, and it's actually within the myometrium. And there's no body to go with it. There's no spine. Here in this patient, it bulges out. These are calcified myomas and not some weird type of demised fetus. A couple other things at the end here. Uterine arteriovenous malformation, that occurs in the myometrium. This is a rare vascular lesion. It's a vascular plexus of arteries and veins with some arteriovenous shunting. There's no intervening capillary network, so the blood goes directly from an artery into a vein. This can happen after some type of trauma, surgery, after a pregnancy, after an abortion, a D&C. So most of them are acquired. A few of them could be congenital. These patients have abnormal heavy bleeding to the point where about 30% of them require transfusions. Now you have to make the diagnosis cautiously, because if you make this diagnosis, D&C is not indicated, because that in itself could cause massive hemorrhage. So surgery would not be the approach. It's a conservative management of this, and nowadays can be even embolized in interventional radiology. So what could we see with ultrasound? Well, the findings are not always specific. Usually you'll see some kind of inhomogeneity in the uterus. Sometimes you may recognize tortuous, tubular, serpiginous kind of structures. Turn on the color Doppler and you see lighting up and a very hypervascular area in the uterus. And you take a tracing with spectral Doppler, and that shows us high velocity but very low resistance waveform. So you have this venous flow, continuous, and you have these little superimposed arterial peaks. The color is intense. There's a mosaic pattern with aliasing, and one should attempt to take a peak systolic velocity. Now, this can mimic retained products of conception. It can mimic abnormal placentation, and gestational trophoblastic disease is in the differential. These patients, so of course a beta would be indicated, a beta HCG level. Now, what about differentiating it from a retained product of conception? Now, that's difficult. There is some information in the literature that tells us that if you do a peak systolic velocity on these vessels, and if it's low, less than 40 centimeters per second, then these are reportedly not requiring any kind of therapy. This is these regress spontaneously. But if you get very high velocity flow, then these are the real arteriovenous malformations that may require treatment, especially if they're bleeding. So I hope that I've given you a spectrum of various myometrial disorders, especially focusing on adenomyosis and unusual manifestations of uterine fibroids. Hopefully this will improve your diagnostic accuracy and lead to the correct diagnosis and subsequently the proper management of your patient. Thank you for your attention.